Welcome to the Endocrine Matters podcast. This podcast episode is sponsored by Complete Medicine and Hey Healthy. I want to talk about something today that I don't think physicians say out loud enough. Something that sits underneath a lot of the conversations we have on this podcast about dismissed symptoms, misdiagnoses, and women who've been told for years that they're fine when they knew they weren't. I loved my training. I really did. I learned an enormous breadth and depth of endocrinology, the physiology, the pathology, the clinical reasoning. That training made me the physician I am. But there is an undercurrent in medical training that I think we need to talk about honestly. An undercurrent of paternalism, of physician knows best, of treating patients, and sometimes women specifically, as though they are problems to be managed rather than people to be partnered with. And I say this not to indict my colleagues or my mentors, many of whom are exceptional. I say it because naming it is the first step to changing it. And because the women sitting in exam rooms across this country deserve physicians who have done that work. I'm Dr. Thangudu, and this is Endocrine Matters. Medical training is long, it is intense, it is in many ways a kind of indoctrination. And I mean that descriptively, not pejoratively. You absorb not just knowledge, but a culture, a set of norms about what expertise looks like, what a good patient looks like, what a productive clinical encounter looks like. And for a long time, that culture has carried an implicit message. The physician is the expert, the patient is the recipient of that expertise, and the transaction flows in one direction. That model made more sense in a different era, when patients had limited access to medical information, when the asymmetry of knowledge between a physician and a patient was vast, and it was perhaps reasonable for the physician to occupy the role of authority. But that era is over, and medicine has been slow to catch up. There's something else I want to name, and it's uncomfortable. Many residency training programs, particularly in academic medical centers, serve predominantly lower income, lower education populations. And I wonder sometimes whether that shapes, in ways that are rarely examined, how trainees learn to communicate with patients. Whether it reinforces a certain posture, a certain assumption about the gap between physician knowledge and patient understanding. Because when that posture gets generalized, when it becomes the default way a physician interacts with all patients, it becomes a problem. And for women patients who already enter the exam room carrying a history of being doubted and dismissed, that posture is particularly damaging. I'm not saying this is conscious. I'm not saying physicians are malicious. I'm saying that training environments shape us in ways we don't always recognize, and that some of what gets shaped is worth examining. Here is a fact that I think should disturb everyone. Only about 7% of family medicine, internal medicine, and OBGYN residents feel adequately prepared to manage menopause. 7%. And more than 20% of residents report receiving no menopause education whatsoever during their training. None. For one of the most universal physiologic transitions in women's lives, a transition that affects mood, sleep, heart health, bone density, cognition, sexuality, and quality of life, a significant portion of the physicians who will care for those women have received essentially no training. How did we get here? Part of the answer is the Women's Health Initiative, the large clinical trial whose 2002 results triggered widespread fear about hormone therapy. When those results were published, hormone therapy prescriptions dropped by about 70 to 80%. And along with them, the clinical attention to menopause management essentially collapsed. Medical curricula contracted. A generation of trainees, my generation, never learned how to have these conversations or how to properly counsel patients about their options. What the WHI results actually showed was more nuanced than the headline suggested. The trial studied older postmenopausal women, average age 63, for the purpose of chronic disease prevention, not symptom management. The risks that were identified were real, but they were largely not applicable to younger women in early menopause seeking relief from significant symptoms. Subsequent analyses made this clear, but the fear was already baked into the culture, and it has proven remarkably sticky. The problem extends beyond menopause. Medical school curricula have historically been built around, as one paper put it, the physiology of a 70-kilogram man. Sex differences in disease presentation, in pharmacology, and cardiovascular risk are undertaught. The hormonal influences on non-reproductive organ systems are undertaught. The psychosocial dimensions of women's health are also undertaught. A content analysis of Canadian medical schools found that fewer than 9% of program documents even mentioned women's health. That is not a gap, that is absence. And patients certainly feel it. Women feel it in exam rooms every day when their symptoms are minimized, when their questions are deflected, when they're told their labs are normal and sent home still unwell. That experience of dismissal is not imagined. It is the downstream consequence of a system that was not built with women at the center. We live in a fundamentally different information environment than the one medicine was built in. More than half of American adults use social media to get health information. Among younger women, the generation coming into peak years of thyroid disease, PCOS, perimenopause, TikTok and Instagram are primary sources of health content. And regardless of socioeconomic status, regardless of education level, people are consuming health information constantly. That is just the reality of the world we practice in now. And here is my honest experience. My patients often know more about a specific topic than I do in the moment. A patient with a rare condition who has spent 3 years reading every paper and connecting with patient communities, she has a depth of lived knowledge and accumulated information that I cannot replicate in a 30-minute appointment. A patient who has been tracking her own symptoms, her own labs, her own responses to treatment for years, she is an expert in her own body in a way that I simply cannot be. I think some physicians experience this as threatening, as an erosion of authority, as the patient overstepping. I experience it as an enormous gift, because a patient who comes in informed, who has questions, who has done research, that patient is my partner. She is helping me to help her. The information asymmetry that once defined the physician-patient relationship is narrowing, and in many ways, that is good for everyone. It can, however, be really challenging. But, and this is a real and important but, the information environment that has made patients more knowledgeable has also made it significantly easier to be dangerously misinformed. Social media algorithms do not optimize for accuracy. They optimize for engagement. And content that is emotionally compelling, that confirms existing fears, that offers simple answers to complex problems, that content spreads. Often faster and often further than content that is nuanced and evidence-based. I have seen patients who have been genuinely harmed by information they found online. Incorrect dosing of supplements, delays in seeking real diagnosis because a social media personality told them they had a condition that turned out to be something entirely different. Fear that prevented them from taking medications they genuinely needed. The information age is not uniformly good for patients. It requires a guide. Someone with the training, the experience, and the ability to synthesize and contextualize that information in the specific clinical situation of a specific human being. I want to say something about artificial intelligence because it is increasingly part of this conversation. AI tools are genuinely impressive. They can synthesize large amounts of medical literature. They can identify patterns. They can answer questions with a fluency and breadth that is remarkable. I use these tools myself. But there are things that clinical judgment does that AI cannot replicate, at least not yet. The ability to sit across from a patient and notice that something is off, not because of a lab value, but because of how she looks, how she is holding herself, the way she pauses before answering a question. The ability to integrate a patient's full history, her family, her life circumstances, her values, into a clinical decision that is specific to her. The ability to say the guidelines say X, but for you, in this particular situation, with your particular history, I think we should consider Y, and to explain why, and to navigate that conversation with her. That synthesis, the kind that draws on training, experience, pattern recognition built over years, and genuine human relationship is not reproducible by an algorithm. It is not reproducible by a wellness influencer with a large following. It is not reproducible by a Facebook group, however supportive and well-intentioned. Those things do have value. They are not medicine. The physician's role in this era is not to be the gatekeeper of information. That ship has sailed. It is to be the person who can help a patient understand what the information means for her specifically. To be the synthesizer, the translator, the trusted guide who holds both the science and the humanity of the situation at the same time. That role is more important now, not less. It requires physicians to show up differently than the paternalistic model allowed. So what does it actually look like to practice medicine collaboratively, to hold expertise and humility at the same time? For me, it starts with curiosity. When a patient comes in having done significant research, even if some of it is inaccurate, I want to understand what she found, what resonated with her, and why. That tells me something about what she's experiencing, what she's afraid of, what she's hoping for. That information is clinically relevant. Dismissing it is not only disrespectful, it's a missed opportunity. It means being honest when I don't know something. Medicine is vast and it is changing rapidly. No physician knows everything. The willingness to say that's a good question and I want to look into it, or I'm not familiar with that study but let me review it, builds trust. Pretending to be omniscient destroys it. It means taking symptoms seriously even when the labs are normal, because the labs are a snapshot. Because reference ranges are population averages that don't always capture individual experience. Because a woman who tells me she doesn't feel well is giving me information, and my job is to take that information seriously and keep looking, not to reassure her and close the chart. And it means being honest about risk. Not in a way that creates fear, but in a way that respects the patient's intelligence and her right to participate in her own care. Shared decision-making is not a box to check. It is the actual practice of medicine done well. Women have been told for too long to trust the system and to stop asking questions. I am asking you to keep asking questions. Find physicians who welcome them. And if you are a physician listening to this, particularly a woman physician, particularly one early in your career, I hope you'll join me in building something different. We have the training, we have the science. What we get to choose is the posture we bring to the room. The dismissal of women's health is not one villain's doing. It is structural, it is cultural, it is encoded in curricula and reinforced in training environments and perpetuated in 5-minute appointments that don't leave room for the full human being sitting across the desk. Changing it requires honesty about where it comes from and a genuine commitment from physicians and from patients and from the institutions that train us to do better. I started this podcast because I believe that information delivered with honesty and respect is one of the most powerful things a physician can offer. Not a prescription, not a protocol. Information and a relationship built on the belief that the patient is the expert on her own experience, and the physician is the expert on the science. And when those things meet with mutual respect, something genuinely good can happen. That's what Endocrine Matters is trying to build. Thank you for being part of it. I'm Dr. Thangudu. If this episode meant something to you, share it with a woman who has felt dismissed, with a physician who is still figuring out what collaborative care looks like, with a trainee who is forming her identity right now. These conversations change things. I believe that.